Welcome to Dental Talk 360. We are a team of 4 dentists, and our focus is to speak about dental topics and how we can make them more accessible and more interpersonal to our patients. I'm Dr. Melanie Silvestrini.
I'm Dr. Santos.
I'm Dr. Sanchez.
I'm Dr. Alfredo, Arauz.
In today's episode, I was very inspired by the fact that a lot of patients do come in with certain instances in which they would need their tooth taken out, whether it's fractured, whether it's non-restorable because of a cavity, and there are options to replace a missing tooth. So today's episode, I would like to speak a lot about how we can replace a teeth and which ways are recommended, and also different options for our patients.
Want to start? Dr. Friend? So for different types of restoration, so whether you're missing a tooth because it was just extracted, or you're just missing a tooth that happened years ago, we have 3 different modalities. We have the removable option, which is something something that we make you like we call it a partial, correct? I'm blanking out. So a partial, something that comes in and out. This used to be the main thing that patients would have had back in the day when we didn't have other implants were not existent, or simply if it was a tooth that didn't have another tooth adjacent to the space, so therefore we couldn't do a bridge. In these partials, you can also put many teeth. So for patients, it was also an affordable route. The only negative side is something that you have to remove every day. It has some sort of movement whenever you're chewing. It's uncomfortable, and nowadays we want everything to be fixed. We want everything to happen now.
Meaning they can't take it off.
Correct. Yeah. Right. In fact, yeah, they cannot take it out. So the other option, whenever you're missing a tooth and it's next to, you have teeth next to the space, you can do what we call the bridge, which we prepare the teeth next to the space, and we put a restoration that sits on it. This is cemented, it's permanent, so you don't have to take it off. And lastly will be implants, dental implants. So I'm gonna have Dr. Alfredo explain you guys a little bit more about removable.
Yeah, so removable partials have been used in dentistry for decades. There's various types of partials that are being made nowadays, whether they're temporary partials or metal partials or even the flexible type. It really depends on the patient, their situation financially, or what's going on in their mouth, right? And at what stage are they at in restoring their mouth. Sometimes we do have to make these partial removable dentures as a middle ground until you're finally done in order to get your final restoration of that implant or that bridge. And these partials are easily done by laboratories. Basically, it's a scan or an impression, and the laboratory will fabricate something that is removable, meaning it goes on and off your mouth. You have to clean it, take care of it. It will wear over time because it is acrylic with plastic teeth on it majority of the time. And it really just serves as a base for you to be able to chew, function. However, for most patients, it's not ideal because it does have, as Dr. Sanchez was mentioning, that movement, especially if it's taking care of teeth in the back, and especially if it's both sides, because now it becomes what's called a lever or a wheelbarrow. It'll go up and it'll move forward and backwards, and it'll attract food, and it'll cause rubbing or irritation of their gums. So for a lot of patients, it's something that's not ideal for them, but it is an option. And even though in my practice, it's not their first option. The first option is always going to be to do an implant, of course, when it's possible. Yeah. However, it is something that with finances or considering wherever they're at in their dental circumstance, it's an option that needs to be presented. Yeah. I feel like whenever we're having the conversation of how to remove, how to take care of a missing tooth, we need to present every option to the patient so that they can make a decision on their own based on our recommendations and facts, and being able to be forthright and honest about the pros and cons of each restoration.
And I've had patients ask me longevity. Is there a difference in longevity between getting an implant or a bridge? And I think it's dependent upon various factors. You want to touch on a little bit about implants and longevity versus getting a bridge, also getting a bridge in an anterior zone versus the posterior and the back teeth, and the differences between those?
Sure. So anytime a patient comes in, we need to get all the diagnostic information up front. So in order to see if they're a candidate for an implant, there needs to be enough bone in the area. Bone sets a tone, tissue is the issue, saying. So take a 3D image. I tell the patient that we're doing dentistry, and dentistry is 3D. So you need to make sure that there's enough bone. If there's enough bone, then they may be a candidate for an immediate implant. If there's not enough bone and they're really strong on that, I want to get the implant, then we can go the guided bone regeneration route. There's always different factors that we can get to the end point. It just depends upon what the patient wants and what the situation is. I guess to go back with the dentures you were talking about, mentioning, I remember making dentures with, they were called precision attachments. Basically they're crowns and then you snap in the denture. Back then, when I was practicing at a Medicare, Medicaid HMO office, I mean, we were doing tons of these, but there's a lot of, it was multifactorial. You had those last teeth that were gonna be with the precision attachments, you need to make sure there's enough bone and enough root structure. Because I tell the patients, how many times do you think you're gonna take this out in a day? Probably 4 times. 4 times 365, you're taking this thing out 1,000 times in a year. So wear, tear, wear, tear, wear, tear. So it's not uncommon for those teeth to start to gain mobility, and then, you know, domino effect, those teeth come out and then more precision attachments. So it depends upon the patient, case selection. If there's patients that have been on, you know, bisphosphonates usage, you'll have to stop it for about a month, 2 months, 3 months, depending upon what their physician recommends. And then, you know, talk to the oral surgeon who you're gonna have to place that in, and, you know, have those restorations done.
So the partials fill a void that some patients need to be able to have in order to chew and function and smile.
Yeah.
Right, but when the case is ideal and you could have an implant placed, whether it's one stage, meaning that we're placing that implant immediately, or 2 stage, meaning that, as Dr. Santos said, let's say you don't have enough bone. Let's say you don't have enough tissue or gum tissue that's correct, and then we have to do bone grafting, meaning we're placing bone into that site. It heals. It could take about, in most implant cases, you're looking at about a year. If you want to be safe, start to finish, right? So especially if you're grafting to build the site. And the best way I could tell the patients is, an implant in essence is a screw, right? You're not going to put a screw on a wall that's not flush and it has cracks and jags everywhere. It's so much more predictable to place it when it's flush and there's enough bone and it's rigid so that it could actually adhere itself to your bone, because that's essentially what an implant does. It has a process called osseointegration, fancy word for just saying that your body becomes one with the implant and it keeps it as part of you. And that's the long-term success of it. However, if there's infection or lack of bone, that implant can fail. In most instances, implant failure rates, what are the percentages of implant failure rates?
So implant failure rates, it's very uncommon. I mean, it can happen to patients just in case. I've had cases where I placed 4 implants in a patient and only one of them failed and the other ones didn't. So, you know, to go a little bit more over, everything has to do, the first thing that I do is always to see if you qualify for an implant. So we have the different options to replace the missing tooth. Now, if you qualify for an implant, meaning you have enough bone, you have enough thickness of bone, you're far away enough from the nerve, you have enough, if you're in the upper, in the maxilla, if you're far away from the sinuses, if you have enough bone in that area. The second thing is your medical history. Are you taking biphosphonates? Are you taking any medications, or are you diabetic? Anything that can cause a delay in healing, or it cannot cause smoking, also a big factor. In general, you know, implant survival rate at 10 years, we have about 91%, while a bridge is about 89%. So they're both very good options. It just needs to, you need to go through a specific cascade of events before we get to the final. First thing is finances. Most cases, let's be realistic. If the patient cannot afford it, okay, then your best thing will be a removable option. It's something that's going to give you function back. You're going to be able to eat at least. That's the most important thing, nutrition.
For a single tooth implant, most patients don't realize that the cost of a bridge is normally the same price as an implant, right? So when the option to get a 3-unit or 4-unit fixed bridge, meaning those teeth are crowns and those crowns are fused together so that they function like your normal teeth. They look like your normal teeth, but they're all bonded together. There's consequences to that. What are those? It's hygiene, right? It's hard to clean when everything is fused together, so you're gonna have to use water picks, make sure that everything's taken care of, because the Achilles of all the bridges is always gonna be those in-between areas of the teeth that then get carried or have cavities over time, right? And that's where that decrease in success rate happens. What are some great instances where a patient is a candidate for a bridge? Let's say they have crowns existing already, and they have a missing space, and those crowns are failing.
Yeah.
Great case, in order to avoid surgery, is to have that done, especially if it's on the top and their sinus, which if there's a missing tooth over time, we'll have that conversation at a later podcast. The sinus drops down and now there's no bone left. And now you have to have sinus surgery, bone grafting, then an implant. However, the two crowns next to their space are failing. It's so much easier and more predictable at that point to just make a bridge.
Also, if you're afraid of surgery, a lot of patients are afraid of surgery and they prefer this route. Also, I always tell patients, like you were mentioning, if you have crowns already, then I'm always going to offer you that option for a bridge, because it's something that, first of all, is done in 3 weeks, about, maybe less. If you have an in-office lab, you can get it done in 1 day. While the implant, you have to wait. It's once you place that implant, you have to wait about 4 months for the implant to heal, to integrate, to become one with the bone. Then it takes another month or so to fabricate the crown, which is the tooth that goes on top of that. So you're looking at about 5 months in general for a place that an ideal site. Now, if you have to add grafting, like Dr. Barr was saying, now you're adding another 3 months to the situation, especially if you have to wait for the graft to take place to then place the implant. So now you're looking at 8-9 months. While a bridge can be done, like I said, either right away or within 2 to 3 weeks.
But I think we would all agree that if the teeth that are next to that space or spaces are virgin teeth, meaning they have no fillings or they have no crowns, then really pushing, having the clinician really stress how important it is to not restore those teeth, because you want to keep your teeth as healthy as possible. So at that point is when we as clinicians in this group, and I speak for all of us, hopefully, that they would really push for an implant, because that is the top tier restorative material for a missing tooth at the end of the day. However, just to go back, fixed bridges, which is when you have two adjacent teeth that are getting crowned to have a fused middle tooth that acts to replace your space, or an implant, are all non-removable restorations, right? So the patient doesn't physically have to remove them, they don't have to take them off. The pros and cons to the bridge, the cons is always going to be hygiene, cleansability. With the implant, the cons are normally, it takes longer to restore those, so it takes the patient a longer time to put those on. The success rate is a lot higher on an implant. For the partial, the pros is economics, price. And the cons on those is always going to be that, one, it's removable, and two, that it's going to move around your mouth. It might cause soreness, it might cause torque or movement of the adjacent teeth, because it does have to rely on those teeth that it's hooked onto in order to function. Okay.
So as you can see, there are definitely different qualifiers for when a patient is missing a tooth, and the most recommended treatment really is case dependent, and it is highly recommended that you speak with your dentist about all of your options, because there usually are more than one option, and each option has its pros and cons. So thank you for listening to our episode, and I'm Dr. Melanie Silvestrini again.
I'm Dr. Oscar Sanchez.
I'm Dr. Alfredo Arauz.
And I'm Dr. Barton Santos.
Thank you.
See you next time.